Welcome to this second appointment, and many thanks to Neo Biotech for the invitation. And the topics of today is basic of clinical regeneration, daily tips and tricks. We know since a long time that regenerative is very important for our dentistry to resolve our cases, and I'm not discovering the rule of regenerative. I want to say something about my mentors because I was lucky to have the honor to know a person like Giampaolo Vincenzi and Carlo Tinti, famous in the 90s for research in regenerative. They are my mentor. Unluckily, Giampaolo Vincenzi is no more with us, but he was really great. And Carlo Tinti is one of my best friends and is a great mentor. In the 2000, I was lucky because I knew Bill Becker and his equipe. And here is a picture. I am the second from the left, and I was very young, and I was very lucky to know him. And he went also many times in Italy, so he teach a lot of things to us. This is my great friend Pinuccio Corrente. Is 2002 when we was together in Boston, the Harvard University, and this is a great professional, and they discover many things in periodontology and implantology. He was a great man, very nice person. And this is more recent, and is Istvan Urban, and I saw him working really a great hand, and I was very satisfied to know this wonderful regenerative of Dr. Urban. These professionals have been and are monsters in my opinion. Today, you will see the regenerative or generic dentist like me, who passes every day from conservative to prosthesis to prevention to regenerative. But there is a key to open the door of regenerative, and here there is a common denominator, always the tissue management, and also the right tools like resorbable membrane, not resorbable membrane, tissue as a fibrin sealant that I show you later. Naturally, there are also other tools, but my practice is on these tools. Now we see a very old case, regeneration with resorbable membrane, 1993. This was one of the first case, and this is a simple case. It was a lesion inside of a bone volume, and was a class 1 dehiscence. Implant surfaces inside of the bone volume. It's a quite easy case, but it's the case that you do tomorrow morning. I put osteoconductive material and membrane fixed with titanium pins. The protocol is from the first cut, on a stick incision, release the flap and put the membrane. As you can see, the flap the flap go up on the occlusal part of the tooth with the periosteal incision. Then you do the mattress suture, and this is the control, the new bone with the roll technique to keep the keratinized tissue that the implant needs. And this is the healing. And I have a follow-up of 8 years. This was an old patient. I didn't see her anymore, but 8 years is enough. Now, in those years, this is a case also very old. I want to show another of this. This a class 1 deletions, the implant surface inside also in the bone volume. And and I use the PTFE membrane fixed with pins this time. You can see the lesion. You must be very careful when you remove the membrane, and you can use the right tools. And it's important, don't leave a piece of the membrane inside. And sometimes you cannot see properly. Oh? Then after the removal, you can see the new bone. This implant was, they were the first regeneration, were implant machine. And this is the prosthesis. And this is before and after. I have a follow-up, 15 years follow-up. The patient is still in my office, and now he went 1 month ago, because I know to do this relation, and in the same time I did it a sinus lift laterally, and I put a CMI implant, as you can see, and now we see 24 years follow-up. Naturally, in these years, there is a gradual bone loss, as you can see also from the literature, from the bibliography. Now we see some more difficult case and more complex case. This is a flute beak fracture. I struck the tooth, and this is the post-extractive site. I leave it for 5 months. And here we have a class 2 adhesions outside of the bone envelope. Naturally, as you can see before, as you saw before, I did a hockey stick full thickness flap. And here I have adhesions outside the bone volume and a short fenestration. This is how you can see the class 2 adhesions. And the fenestration is outside of the bone volume. So we did also here the regenerative with the PTFE membrane and homologous and osteoinductive materials. We fixed with the pins, and the flap descend as usual under the occlusal part of the mouth of the tooth, of the teeth. This is the healing, a very good healing. And this is the second stage, moving the membrane very softly. And this is the regeneration. Very good regeneration, always with the Gore-Tex membrane, with the PTFE. And in this case, I did a connective tissue graft from the palatal side to reinforce the keratinized tissue. And I have a follow-up of 3 years. But now come nowadays, this is more recent, is a very, very compromised tooth. And I put only some osteoconductive material and collagen in the site, then I wait. This is the X-ray after the extraction, and this is before the surgery. The socket preservation is a technique that I use in more often now, because it gives me a lot of satisfactions. This is the view of the case. As you can see, this is from the palatal side, and this is the surgery. Hockey stick incision, intracircular, full thickness. We move the flap with the CTGO then with the Pritchard. And this is the fenestration. We have not a good quality of bone in this case. And we put the implant, as you can see, and we perforate to make the bone bleed. And the patient asked me absolutely that want his own bone, and I told him that his own the best was his own bone with osteoconductive material. So what that we did, collecting the bone with a scraper from the mandible side, as you can see here. And then we manage the tissue, and this is constant, the management of the tissue, because it's the most important part of the regenerative in my view. Then we put this membrane reinforced with titanium, and we put these titanium pins to fix the membrane. So the steps are: shape the membrane with sharp scissor before and place the pin, then the membrane far at least 1 millimeter to the adhesion tooth, and the mix of autogenous and osteoconductive material is the best. Then we did the mattress suture first, and the second, we made a modified mattress suture, and this Gotland suture. This is the X-ray, and this is the healing of the patient. Now we go to the second stage, and in the second stage, we remove gently the membrane with chisel and the CTGO, and the incision is without touching the adjacent papilla. We remove the pin very carefully, and we move also the membrane, and you can see now the new bone. As you can see, there was so much new bone that I remove it with the chisels. Then I put the healing caps, and then the suture. This is the acrylic holder of the abutment to put in the right position, because this is an abutment without finishing line. And this is the case finished with the radiographic control. And this is the bibliography from Ignazio Loi that use very often this preparation with the technique BOPT. And there are a lot of articles on the literature about this kind of prosthesis. Now we see another case. This case is a malpractice implant, is a fracture, and this patient came from Sardinia, and she breaks the implant, and there was such a problem because she had not enough time. I have to make many things at the same time. Now we see this is the step one, and what I did with the piezo, I did the osteotomy to remove the implant. That was very, very difficult, I tell you. And I did exactly a block section of the implant, and I removed, after a lot of fatigue, the implant. Then I collect the bone, and I put a resorbable membrane in the inured site and the implant at the same time. And I put the membrane with the pin. Then I did the suture, I moved the flap, and I left the patient go to Sardinia, and then she came back after some months. And this is after 8 months, I have the implant perfectly integrated. Now I'm waiting for the maturation of the tissue that now is under control. And this is the X-ray of the case. And this is the control. Naturally, sometimes we have patients that have not enough time and we have to force our technique, of course. Next case is very interesting because this is a second premolar fracture, and the program is a post-extractive implant with no functional load. I was ready to do this, but you can see that I did the intracircular incision, but I missed a little bit the diagnosis because I didn't see the extremely compromised palatal wall. There was a big lesion. So I clean it nicely with the spoon, the post-extractive site, and also with the piezo. And in this case, the wise clinician must stop in front of situations that overtake the limit of the protocol. It's not enough a big hurt. You must have clinical sensitivity. And in this case, the best is to regenerate the post-extractive socket. And from the bibliography that we found, a lot of literature about this. And you can do with the many materials, with the collagen, with the deproteinized bovine bone. 3 months after, a collagen cross-linked membrane with pins was fixed to make regeneration. And this is the surgery, the flap. And as you can see, we regenerate enough bone in this case. Then we put the implant and the membrane with the pin. This was a class 1 dehiscence. Implant surface is inside still the bone volume. And to obtain a right regeneration, the blood clot needs more wall is possible, like in the glass of the wine. This is the healing, always the same procedure. Then the healing cup and the prosthesis of the case. And the case finished. But in this case, we had also a very big lesion of the endolesion here on the mesial root. And what we did the endosurgery. And at the same time, we took a carrot of the bone, and we did endosurgery. And this is the histology of the bone taken. So we had a very good quality on air-formed bone with the excellent quality of bone itself. Some years later, we did another implant, and we did sinus leaf from recrestal. Now we see some frontal teeth, Here we change philosophy. We change the approach of in this case, no? This was a very compromised tooth. And I used also here an alveolar ridge preservation using the proteinized bovine bone. And we see from the bibliography that can preserve the original ridge volume and the support bone formation contribute to adequate bone volume for implant section. So this is the CBCT, and you can see the lesion. And here you can see that all the wall was gone. So we did an atraumatic extraction. And as you can see, we have a buccal lesion, a class 1 dehiscence is inside the bone volume. And you can see how much was the lesion. The buccal is completely gone. So changing philosophy, we regenerate the wall, the buccal wall, with fly os and cross-linked membrane with this icon technique. Icon technique is described from Dennis Tarnow, and I did it properly. I put all the material inside, and then I put the icon inside. Then I put the membrane, and I suture it. This is the membrane suture. We have also bibliography that said that the dental implants in preserved and non-preserved post-extraction is say that it's better to preserve the socket. This is the tooth. I put a cemented Maryland bridge as temporary, and this is after 5 months. 5 months, I did the surgery, and the surgery was quite well. And I put the implant, and the result was very nice. This is after surgery. Then we wait some more time. You can see also the quality of the regeneration from the X-ray that show the quality of the regeneration. Then the second stage, we move the tissue, the keratinized tissue, with a cut with a 15 blade, and we see TGO moving buccally the keratinized tissue and put in the healing cup. A transfer copy pickup from Neobiotech, as you can see here, and we took the impression. But what interests in this case is the quality of the tissue and maturing the gingiva with abutment without finishing line. So I moved the temporary, moving also the quality and the gingiva with this technique that is described from the Ignazio Loi. And this is the case finished with the X-ray. Straight marginal abutment is a different philosophy, because with the BOTPT, the biological oriented preparation technique, is the temporary that moves the gingiva around the implant. But I don't want to discuss about this, because could be an entire argument of a conference, because in Italy many school schools does this. And this is the case finished with the beautiful gingiva. BOPT, for the most correct management of the emergency profiles, is a good technique. I wrote also an article in 2012. But now we see another case, and these are all cases that happen in an office like me, that makes general practice, and you have to resolve this problem, because this patient came in my office but he didn't know to have a lesion like this one. I took the X-ray. I told him, listen, but here the tooth is completely broken. Ah, yeah. So I proposed the extraction with the regeneration of alveolus. So I programmed this, and I did it. I clean very, very well the alveolus, and with the spoon and with the piezo. And then in this case, I put the tissue buster with the osteoinductive material inside, and I close the post-extractive site with a free gingival graft taken from the palate. And this is the tooth, how it was, really horrible. The radiographic evaluation of the regenerated tissue after some months is this one. So it's quite well, it's quite good. And the CBCT shows another great lesion, endolesion of the first root in the upper molar. So I did the endosurgery. I put the material, the retrofilling, and I put also the implant. I fixed the implant. There was a fenestration steel, and I regenerate a little bit in this case with the resorber membrane and osteoinductive material. I fixed the membrane, resorber membrane, cross-linked membrane, as I use usually in this case, and I sutured with this mattress sutured, like is described in this article from Istvan Urban and Company. Then the healing cup, then the prosthetic passage. This is baseline, and this is after 6 months. And this is the case. And now we see from the 2015 to 2021. We proceed with the difficulties of the case. And this is a fractured molar of my old patient. This is an old lady. We did also a prosthesis, an acrylic prosthesis, because she is not very rich, and I did this kind of a solution. And in this case, I removed the tooth, and I have a very big lesion with the very big dehiscence. In this case, there is an horizontal ridge deficiency. All 8 of the implant was out of the bone, as you can see from this drawing. And the vestibular lingual bone defect, due to lack of bone thickness more than 50% of the implant diameter. So what I did regenerative. I put a resorbable, long-term resorbable membrane. I sutured to the periosteum, and I close with connective tissue graft, because it was a post-extractive site. And now we see the sequence of the healing that I think that is very, very, very good in my personal opinion. And now the healing in this picture, I couldn't take the X-ray to this patient for a problem, and I took the orthopantomography. And this is the follow-up after 9 years. Loading. Now we see some more cases, very, very difficult in my personal opinion. If I can, I avoid to do this case, but sometimes you have to do. Otherwise, the patient go to another dentist. And but if you know the technique, you can do also this. You are not the best in the world, but if you know how to manage the tissue, you can manage. Also, you knowing very well the anatomy, you can do it. And it's harvested from the crest of the patient, the bone, with this scraper. But when I prepare the site, you see a big dehiscence in this case. As you can see, look how much is out of the bone here, no? Then we put the membrane, we put the bone, we stimulate the bone with these small holes, and we did our mattress suture and the Gotler suture, as I show you since from the beginning of this speech. This is a new bone. The new bone was formed. We removed the membrane, and this is the case. And also in this case, that is quite difficult because also the patient it didn't open well the mouth, and was quite difficult. And but I have 6 years follow-up. Now we go and we proceed with another difficult case. Here there are prosthesis problem, implant problem, a lot of problems. And but especially there was a vertical deficiency, and what to do in this case? In this case, the program was to elevate the bone and making the technique that I am going to show. That is the technique of Carlo Tinti, Simeon, and Istvan Urban. This Istvan Urban, he has modified a little bit this technique a little bit. But we do this crestal incision with the 15 blade, and we go buccally 1 tooth ahead, and lingually we go 2 teeth ahead. Naturally, we have to take care buccally to the nerve, and on the lingual part, we detach the malleolus muscles and all the gingiva, and we put the bone nude, and we do a full thickness detachment of myelus fiber. And what we do, a superficial muscular fiber section, and we must be very, very, very careful using the blade at the beginning reverse, not from the sharp part I use usually, but from the reverse. So you detach the fibers, then you practice the detention of the muscles with this Brannemark chisel, or the best could be the mini-me is PFIWDS1MK from U3D. And the flaps slips without stress. Naturally, on the buccal part, you have to isolate the nerve, and with the 15 blade, and you make the incision on the periosteum, but you must be very careful going around the nerve itself. So this is a draw, and this is the clinic. So buccal and lingual flap coronalization without stress. Then in this case, I put with acrylic template the implants, and you see we did a cortical bone perforation. The cortical bone perforation is very important because give us more blood with the factors. And then in this case, I put a resorber membrane, but positioning with the pins by the lingual part. But it's very important to see what we are going to do, because on the lingual part we have a lot of anatomical nerve and vessels and sublingual gland. So it's very important to know the anatomy of this part. When you elevate the muscles, you must go on this part and not inside. You slip up the fibers, and you have to take care there, because we repeat, we have the muscle insertion, the myelinoideo muscles, sublingual gland. There is the Wharton duct, the lingual nerve, the lingual vein, hypoglossus nerve more deeply, and the lingual artery as well. And this is an article of an Italian, Marco Ronda, is a very good surgeon that makes this movement of the flap. Then we put the membrane, we position the membrane, and then this is the suture, as usual, the mattress suture and the gotlo. And after drawing, the clinic. This is the healing, of the case. And in the second stage, I always make a connective flap to strain the missing fibromucosa. And this is the case from the point of prosthetic point of view. And I show you now the follow-up. This is a follow-up of 14 years. Now we speak about a little bit about the T-cell regeneration technique. Here you can see two good friends of mine that are Dr. Corrente and Roberto Bunto. Roberto Bunto is really great. And in the in the 90s, they did a lot of article on supracrystal bone regeneration about implant using calcium carbonate and fibronectin selling system. This technique gave me a lot of satisfaction and comes from an intuition of Dr. Corrente that always went on his way. In a time where there was growing up the technique of the Gore-Tex membrane, and he had a lot of satisfaction, but also me, I have a lot of satisfaction. So when the worldwide regenerative proceeded on a membrane regeneration, he did these cases. And I want to remember him because he was dear to me. He was a great man. And he did also long-term evaluation of integrated implants in regenerated and unregenerated bone. And also the American Academy of Periodontology and the European Academy of Periodontology wrote article about this. But now we see some cases. I simply applied the technique. In this case, I have a post-extractive class 2, and the extraction was very tricky, and the tooth was completely in ankylosis, and all the wall went out. So I put the implant, and I use the T-cell. The T-cell is a preparation that is ready for use, must be conserved at below 18, and the cold chain must never be interrupted. And when you defrost, you must be stored at room temperature. And if somebody is interested in it, you can find a beautiful webinar of my friend, Dr. Michele Perelli, on Dental Med TV for preparation of T-cell. For brevity, I don't speak about this. Anyway, the component one is human coagulable protein solution, human fibrinogen, and bovine protein. The second component, thrombin and calcium chloride. When you prepare for dentistry, you leave only the 10% of thrombin inside. Then I did the regeneration with T-cell buster and endobone xenograft granules and resorbable membrane. I did also the connective graft closing to close the post-extractive and the sutured. And this is the regenerative of this T-cell before and after. And also here I have a very good follow-up. 4 years of load. This is a very good follow-up. It is a nice case. Now we see this patient that was a professor, and he had such a problem of decementation of this bridge, and this bridge was completely compromised. So the project was to make implants and to regenerate the site and make post-extractive. You see, they are very compromised teeth with resorption. So this is the case. The first slide. We did surgery, post-extractive implant. We removed the bridge, and we had fenestration, and we must do also regenerative because the anatomy of the maxilla. We put the implants, the 2 implants, and then we put the implant in position 1.1, but the crest was very, very thin. So I prepared, I did like a split crest, and and I prepared with piezo. Then I put the implant, I stimulate the bone, and I use the tissue as osteoconductive material. I put always the tetracycline inside, and I fix with resorber membrane, closely membrane, with these titanium pins, like a wafer biscuit technique. And you see here, in the same time, I put the temporary abutment and acrylic provisional. And this is just after the surgery. This is the X-ray. After 5 months, this was the situation. And I did prosthesis. And this is the ceramic. And this is the tissue, very nice and very, very white. But most important is the control. The control tell me that the regenerative is working at 18 months of loading. And this is 2 years follow-up. And this is the aesthetic. Now, with this wonderful picture, I want to finish with this case that a case that is the case that don't make you sleep during the night, because some years ago came in my office this lady. She went from Belgium. It was the daughter of a very important person, and the situation was this one. The situation was this one with a great problems with the teeth missed, and with the terrible periodontal or periodontal problems. But this was not properly periodontal. She doesn't care at all about her mouth, especially. The case is the patient does not know the severity of the problem. The patient wants to restore her original mouth. There are no problem and willing to do anything. Aesthetic problem, provisional problem, and male regenerative problems. In this case, I use all the tools: resorbable membrane, not resorbable membrane, tissue, fibrin sealant. But the problem was also the temporary and to treat the infection. So the problem was to treat the teeth before, to restore the situation from the periodontal point of view, and to clean. This was the lesion. I stay with these tools because it was important for me for the temporary to keep the temporary on, and then I start with the regenerative with not resorbable membrane, like we showed you before. Not resorbable membrane. We put the material and we regenerate, we suture it, and this is after 1 week. This is after some months, and this is the membrane, and this is the new bone regenerated. In the same time, we went on the maxilla, and the problem was the temporary, because I put these 2 pins with the ball attachment, And I know that I should have had problem because the temporary, but the patient was very patient. So the day of surgery, we put the implant, and was terrible, the lesion. And we exploited this lesion to elevate the sinus on this way. You can see we elevate the sinus, then we put the implant. And this was adhesions, and we fix it with the fibronectin and with the membrane. Then we close it. And this is after the surgery. There was a small exposure of the membrane, resorbable membrane, after 1 week. But this membrane also, if you are exposed, then with the T cell, there is no problem at all. The problem was the temporary that doesn't touch the regeneration. So we did the prosthesis in the upper and in the lower. The ceramic in the upper and the lower. But I want to show only, not to make me orgullosos or proud of myself, but only to show the potential of the regenerative in this case. There was a great potential, but it was done before a correct project of this rehabilitation. This is 4 years loading. This was at the beginning, and this is 4 years loading. Then this patient went to Portugal to retire, and she come only sometimes in my office, but he went at least 1 or 2 years, two times per year. And this is the follow-up with the picture that I did 1 month ago. And more than the colored aesthetic is very important, the black and white aesthetic, because it shows us how it works, our regenerative. I can tell you that in this case, the problem is coming from the endo of the 4.6. So I launched the stone on the sea of the regenerative, and I want to make some conclusion. The conclusion is the correct management of the flaps, the depth knowledge of the technique, the maintenance of the blood clot, good anatomic knowledge, and respect of the bone maturation times. If we wait, is correct. And a phrase of a person that is dear to me: remember, when you hear medical report, and the end you have more question than answer, you're on the good road. Nothing is so sure in medicine. A wise doctor is a big friend of mine. So I tell you many thanks for the kind attention, and to the Neo Biotech for the invitation and for the opportunity that gave to me. And I'm very happy, and I hope to see you soon in person, of course. Thank you so much.